welcome. Dr. Kuderer is going to be speaking to us about constructing a standard of care, challenges in pathway development for advanced breast cancer. Thank you very much.
Thank you so much for coming back from lunch. I'm coming here from Seattle, and it's my distinct pleasure to going through a lot of new data. I am consultant for quite a few companies, but not on the Speakers Bureau. I do sit on ASCO and have been on NCCN guidelines and don't own any direct stock. We have a lot of data, so we won't have time to go through the learning objectives. You all are familiar with the clinical and socioeconomic challenges, so again, I will not bother you with those details. Just to highlight, as you are well aware of more than most in academia, the financial toxicity of our patients is mounting yearly, and there is no relief in sight, unfortunately. There are a lot of teams discussing this, researching this, involved with policymakers, but it is a major challenge for our patients. That's become a major discussion point in therapy. Talking briefly about pathways, you're well aware of NCCN guidelines and that they've partnered with McKesson. Since 2012, they even done a survey at the beginning, and it appears pathways help clinicians. We hope so anyway. For most at the time, did not think it decreased quality of care, but I'm sure those aspects have changed as well, and I'd love to actually have a discussion afterwards with the audience, what your experience has been. The word pathway is not the same for everyone. It depends on the perspective of the developer. And again, I think this audience is well educated, and I'd love to hear more. There can be issues, single institutions. It may reflect their objective and restraints. Some pathways, especially large oncology groups, has a particular focus on clinical trials, which is important, but it may deflect from some other important issues along the way, including supportive care potentially, as well as commercial pathways may be driven by rebates and other financial incentives, so there are some caveats there. So therefore, ASCO has come up with formal ASCO pathway guidance. Robin Zahn has led the effort with a nice team, including Gary Lyman and Linda Bosselman. And just a caveat, Dr. Lyman is my husband, so there's some additional disclosure there. So the pathways are supposed to be driven by experts, should be transparent and comprehensive. Implementation, obviously, they should be user-friendly, and I encourage you to read through. I think it might be helpful if you have not had the chance yet. And they should be really, there should be analytics. We should look at outcomes. We should look at performance. Again, we should know who sits on the panels, how these guidance or these pathways are doing, and promote research and quality improvement along the way. But let's hit the data for metastatic breast cancer. A lot of new exciting things have come along, including ESMO. We just came back from Barcelona, and it's been probably one of the most remarkable breast cancer large conferences we can remember. Just briefly to discuss outcomes data, overall survival versus progression-free survival. A gentle reminder, progression-free survival is only a surrogate and really is only there to guide us which treatments will likely develop overall survival improvement, but it does not guarantee it. So a progression-free survival improvement does not guarantee the patient lives longer, and by itself, it doesn't improve the quality of life either. And there's poor correlation with quality of life. So a treatment that fails to show overall survival improvement and fails to show a quality of life improvement is not truly beneficial to your patient. And I think sometimes we forget that as it gets used for early approval by the FDA. So quality of life is a patient-centered outcome that will come more and more. And the FDA is working on formal guidance there as well. You probably have heard that as well. We've had challenges in metastatic breast cancer over the last decade to really improve overall survival. More recent, especially endocrine therapy, has changed that, and we'll go through the data. You're all very familiar with the molecular subtypes, including the intrinsic subtypes, but now we're finally starting to see the molecular revolution take shape and impact our clinical care and challenge our clinical care. So as you're well aware of, in the ERP-positive space, PIK3CA mutations, BRCA mutations have now entered formal FDA-approved drugs. ESR1 mutations are not yet ready for prime time. I think that has been confused somewhat in in the community, including academic medical centers, in the basal cell or triple-negative breast cancer setting. We do again have the recommendations, and we have now PD-L1 expression data. And in the HER2 setting, there will be some biomarkers, novel biomarkers coming along as well, but they're not quite yet ready for prime time either. And down at the bottom, there will be hopefully many more coming in the not so distant future. So let's look at the recent updates in ER-positive breast cancer. It has been an acceleration of FDA approval, and on here we don't even yet have the PARP inhibitors. So looking at what has particularly changed since recent NCCN updates, the mTOR inhibitors we have already had, the CDK4/6 inhibitors we have already had, but we have now more overall survival data, and we now have alpelisib together with fulvestrant in PIK3CA mutant breast cancer. Just to remind yourself, not to go into any detail, but the various pathways that we're targeting in ER-positive breast cancer, this is a slide to take home with you, and you can kind of familiarize yourself. Why are we looking at these agents? And theoretically, they all make sense, and CDK4/6 inhibitors are a really central part in the pathway inhibition and have really changed the face of ER-positive breast cancer, and we'll go through the data now. So the unmet need of premenopausal women and CDK4/6 data, you've heard the MONALEESA data already with comparing ribociclib plus AI or TAM and ovarian suppression versus placebo. And we have heard the nice overall survival improvement for these data, and it's been quite impressive, the hazard ratio of 0.71, and we have not reached median overall survival. It's been shown in the major subgroups as well, so we are comfortable that most patients should benefit from this effort. No new safety data were found in the premenopausal space. Caveat, however, tamoxifen is not officially approved, only for nonsteroidal AIs plus ovarian suppression. And we've heard recently this pneumonitis risk, 1 to 3% across CDK4/6 inhibitor agents. We don't have much detail on this. Supposedly only less than 1% events are fatal, but clearly more needs to be learned about this, and that goes across CDK4/6 inhibitors. Now, we've had until ESMO this year some phase 2 data in premenopausal women, including palbo plus AI and ovarian suppression compared to capecitabine. It's a phase 2 study, so it's not definitive data, but again, encouraging a very similar hazard ratio in the 0.65, 0.7 range, probably very similar benefit, but not phase 3 data. And again, the subgroups look very encouraging as well. So looking across the major phase 3 trials of CDK4/6 inhibitors, overall survival, we've had PALOMA-3 showing overall survival data in postmenopausal women. We've had MONALEESA-7 that you've been aware of in premenopausal women showing overall survival improvement. And now since ESMO 2019, we also have overall survival improvement for abemaciclib plus fulvestrant in premenopausal women, both in the first and second line metastatic disease, and we have ribociclib plus fulvestrant overall survival improvement in postmenopausal women, first and second line. So now we have overall survival improvement across all 3 agents, with now ribociclib actually having both in conjunction with fulvestrant as well as in conjunction with aromatase inhibitors showing the overall survival improvement. We have it across premenopausal and postmenopausal women as well as early stage or first line as well as second line therapy. So that's second line data. This is the first line overall survival improvement data. So looking at MONARCH 2, nearly 700 patients were randomized 2-to-1 to abemaciclib versus placebo. The overall survival, I don't even show you progression-free survival, we don't even have time for that. Overall survival improvement and over 9 months improvement, hazard ratio of 0.75. Mona Lisa, comparing ribociclib versus placebo in postmenopausal women, including men, over 700 patients. Overall survival was the secondary outcome, yet it shows a nice overall survival improvement with a hazard ratio of 0.72, so all very similar. They're all in that same range, that 0.7 range. Median overall survival has not been reached, but it's at 36 months and 42 months, 9 and 12% difference. In the landmark analysis, a nice p-value showing superiority. Just a reminder, this was the Paloma overall survival data, only around 500 patients. Similar hazard ratios, although in the 0.8 range, but this was a more heavily pre-treated patient population. And that's a reminder here that the efficacy data, and this is now looking at progression-free survival data for these trials, is we should not compare across trials because the level of pre-treatment in the control arm or in these patient populations was different, and therefore the progression-free survival in the control arm decreases and does not reflect drug efficacy differences. Just to remind you, the everolimus data that we've had in Bolero-2 compared to AI did not show an overall survival improvement. We had in a small study, everolimus plus tamoxifen in the TAMARACK study, we did see an overall survival improvement, but again, small study. So more limited data, probably a tougher toxicity profile for everolimus now compared to CDK4/6 inhibitors. This is just a summary slide. Again, we won't go into the details, but for your records, that we have now a nice overall survival improvement across these trials, including first and second line, but limited for everolimus plus AI. Briefly, subgroup analysis that was shown at ESMO. We don't have time, unfortunately, to go through the data, but the take-home message is, which you can take into your clinical practice, CDK4/6 inhibitors not only improve progression-free survival, but also overall survival in first and second line in metastatic ER-positive breast cancer patients. It's irrespective of prior line of therapy as well as endocrine sensitivity, so these studies nicely went into the detailed data, and everybody's in agreement that that's the take-home message. As well as site of metastases and menopausal status, at least currently, we don't think there is any obvious difference with the caveat subgroup analysis. They're underpowered, so we won't get that p-value, we won't get the confidence intervals, and we should not compare across trials. And so far, we have no biomarkers to identify, select a subgroup where we can hold off with CDK4/6 inhibitors. Hopefully, this will change. As well, the hope is, and the discussion has started, that we need a large meta-analysis that combines the individual patient data for these trials to really dig into these subgroups. There might be differences. Currently, we cannot differentiate, but hopefully we can further drill down. But currently, for visceral disease as well as lung metastases, did not appear to be a difference for CDK4/6 inhibitor efficacy versus not. The other major question that's come out of ESMO, particularly, again, the need for quality of life data and real-world toxicity data, also, again, in light of this pneumonitis story that's developing and will probably increase, especially for our geriatric patients, as quality of life clearly changes as patients. You as clinicians, you see this. It's a very different story to take the combo versus an AI alone, especially for our older and comorbid patients, especially also sicker, and we don't even know the details yet about how comorbidities affect us. So we do need to become more personalized, and we do need to guide our patients that this impacts your quality of life if this is of value to them. So in summary, we have palbociclib first-line data, progression after endocrine therapy data. We have premenopausal data, although that's now only phase 2 data. We now have ribociclib first-line data for premenopausal women, and second-line data with fulvestrant. And we have abemaciclib now that now has the most comprehensive list of data. First-line progression after endocrine therapy, premenopausal data first and second line, and we have the monotherapy data, although it's question what to do with that. caveats, as you're well aware of probably already. CNS penetration, abemaciclib appears to have superiority there, or not superiority, but probably is the preferred agent in some of these brain metastases. They all have neutropenia and thrombocytopenia to various effects. As you know, the ribociclib has the issue of LFTs as well as QTC syndrome or QTC prolongation, and abemaciclib has the major diarrhea issue, and that has been a real issue in my practice, and I know many of my colleagues as well. So the future of CDK4/6 inhibitors, so while we have looked at the traditional endpoints of progression-free survival as the surrogate, and finally we do have the definitive overall survival data, what I think will actually further drive this practice is the patient-related outcomes, especially quality of life, but also time to chemotherapy, and these agents have shown at ESMO to prolong, to delay chemotherapy start, but also pain relief. And then sequence, how should we sequence the agents? There are trials underway to compare that as well. Potential future biomarkers. There has been a nice analysis from the Memorial Sloan Kettering group at ASCO. Again, a busy slide, over 800 patients. Take-home message there is we are in the process of understanding resistance mechanism better, but we do not have any definitive biomarkers. So this will give us a hypothesis of what combinations to use, but in clinical practice, not yet ready for prime time. How about PIK3CA in ER-positive metastatic breast cancer? You're all aware of SOLAR-1, the phase 3 randomized double-blind placebo-controlled trial of alpelisib in metastatic ER-positive HER2-negative breast cancer. It was assessed across mutant and non-mutant patients, but the primary hypothesis that this would be only effective in mutant patients, and clearly that's what the data are showing us. So looking at tumor tissue in PIK3CA mutant patients, we have an over 5-month improvement in progression-free survival. The overall survival data is still pending, but FDA appropriately has approved this. It can be used in clinical care. Now, they also looked at ctDNA with the caveat, and they showed a nice improvement as well in efficacy. But I should caution you, the assays are not really ready in breast cancer use, and we should really focus on tissue, and ctDNA should only be looked at if you really don't have access to tissue, and it should be really the metastatic biopsy we should look at. How about checkpoint inhibitors in ER-positive breast cancer? We can make this very quick. We won't even look at the study design because we have curves that are overlapping. And while it was just a phase 2 study adding pembrolizumab to eribulin, clearly there is no efficacy benefit here, and this is not going to be further developed without biomarkers, which is where we should be going anyway. So updates in triple-negative breast cancer. We have IMpassion 130 study. You've heard again last year and this year at ASCO it was updated, looking at atezolizumab plus nab-paclitaxel compared to placebo plus nab-paclitaxel. This is in first-line patients without any prior therapy. And these were co-primary endpoints, both for the ITT population looking at progression-free and overall survival, as well as the subgroup of PD-L1 positive patients, which makes it 4 comparison groups, and they were only supposed to look at the overall survival data in the PD-L1 positive subgroup. If the overall survival data in the ITT group was positive, did not quite meet that. So officially, we should not be looking at the overall survival in the PD-L1 subgroup. So there are a lot of caveats here. But overall, progression-free survival not improved in the ITT group, and not surprising, was improved by about 2.5 months in the PD-L1 positive subgroup. Again, overall survival, we did not have a definitive overall survival improvement in the ITT population, so we really shouldn't be looking at the overall survival in the PD-L1 positive group, but we are, because there appears to be a very promising trend in the 5 to 7 month range, although it's very small patient numbers. This could be a fluke of small patient numbers and imbalances in other response biomarkers such as TILs and many other that are being looked at or under development that have not panned out yet in breast cancer in a definitive fashion. So there are questions there. How meaningful this is in breast cancer. Nevertheless, the FDA, rightfully so, as this is such a patient group in need, has given accelerated approval, but we will be getting follow-up trials in the space looking at PD-L1 inhibitors plus chemotherapy in metastatic triple-negative breast cancer to confirm that these are truly meaningful data that can be confirmed in future trials. What has been really helpful at ESMO is Hope Ruger's presentation, actually looking at the PD-L1 IHC assays, which have been giving us a lot of headaches as breast cancer uses a different assay as other tumor types to assess PD-L1 status. So this was a post-hoc exploratory analysis comparing the three major assays, IHC assays available to assess PD-L1. And the first line is the take-home message. The approved assay that has been approved by the FDA for atezolizumab in breast cancer, the SP142 from Ventana, at 1% cutoff is the approved test and remains the standard of care. It shows the best efficacy, actually, interestingly enough. It's essentially a subgroup of PD-L1 positive patients when you compare them to the other assays. About only 64% of the 22C3 and 69% of the SP263 are positive by SP142 standard assay. So by luck, they had the right assay and they found the more responsive subgroup. And so this is the subgroup that appears to be deriving the most benefit from atezolizumab. When you add the other patients that are positive with the other assays, the benefit nearly disappears. Also, what came out of the presentations at ASCO, including other individuals, that there are differences in PD-L1 positivity between metastatic site versus the primary tumor. The primary tumor is more likely to be positive. The biology, there tends to be more TILs as well in the primary tumor. So again, we do want to interrogate, if at all possible, the metastatic site. Interestingly enough, we saw some very early data that there are also differences in the type of metastasis that you biopsy to determine positivity. We don't know yet what this means clinically. It appears, not surprisingly, for example, that lymph nodes are much more likely to be PD-L1 positive than especially liver metastases. Lung also appears to be more positive. And again, we don't know why this is, but again, it could be that maybe the non-tumor associated lymphatic systems that are more prominent in those organs might actually affect our assay. Would not be a surprise. Again, we don't know how clinically meaningful this is, but if you can, I would shy away from especially using lymph nodes for your assessing your PD-L1 status. Here are other agents that are coming along in triple-negative breast cancer. They're not yet approved. They don't have yet phase 3 data. Many of you have put patients on trials, especially sacituzumab looks very interesting. We won't go through the details here, but just to remind yourself and why we're not talking more about them, as we're not yet using them clinically outside of clinical trials. Oh, just coming back to androgen receptors, many academic institutions will assess androgen receptor status, but again, we don't have phase 3 data. It is kind of a last effort that some of us, and including myself, I have to admit, I have used, but it's not officially part of our pathways either. So looking at NCCN for triple-negative breast cancer, or obviously endocrine-resistant breast cancer. You're well aware of these data. The preferred agents are especially anthracyclines and taxanes. Then we have additional agents that we can use. And we now have the PARP inhibitors, not just olaparib, but also talazoparib, that has become available now, both in triple-negative breast cancer as well as ER-positive breast cancer, as long as they're HER2-negative and BRCA1 or BRCA2 germline mutant. Now we've just discussed the atezolizumab and nab-paclitaxel data. Just briefly, to review the Olympiad olaparib data and the BRCA data, both FDA-approved PARP inhibitors. They have been assessed now in germline mutant BRCA1 or 2 positive, HER2 negative metastatic breast cancer patients compared to the choice of standard chemotherapy, but not compared to platinums, as you're aware of, or taxanes. What's valuable in that comparison is that even compared to the better-tolerated chemotherapies, these agents not only improve progression-free survival by about 3 months, have a much better response rate compared to single-agent chemotherapy in the 60% range and compared to the 25 to 30% range for single-agent chemotherapy. The serious adverse event rates appear to be favorable, although talazoparib does have more serious hematologic adverse events compared to olaparib. So again, the toxicity profiles matter to us clinically and to patients and clearly should be discussed. So PARP inhibitors are the preferred agents for many mutant BRCA mutant breast cancer patients, probably in the absence of a visceral crisis. We have very little data there. I probably would go with a dual chemotherapy agent, although even that can be discussed at this point. Compared to single-agent chemotherapy, we have the better relative response rate. We have the better quality of life data that we're not discussing today, and we have this potential for prolonged disease control. It's a small subgroup, anywhere in the 5 to 10% range probably. Those data are still emerging. They're still kind of hush-hush being discussed in the background. But we really don't have that with chemotherapy either. So for those patients, this is huge, right? If we can keep them controlled with PARP inhibitor alone for many months to some potentially years, it's a huge quality of life impact and disease control. It probably makes the difference if they go to work or on disability. Also, PARP inhibitors, we don't have yet the data specifically, but it appears more and more that patients who have been on platinums are likely resistant to PARP inhibitors. So while these data are not definitive, most in the academic setting strongly recommend that if it's a mutant patient, BRCA mutant patient, a PARP inhibitor should be used first. It's unclear if platinums will still work afterwards. We will try it. In a few patients, we have been successful, but there's likely cross-resistance both ways, but particularly if the platinum therapy was before PARP inhibitor therapy. They're also likely more effective in the first line compared to subsequent line, again, early emerging data. Nothing definitive yet there. And we've discussed already in detail atezolizumab in PD-L1 positive patient that we need confirmatory trials, as this is a kind of nearly a post-hoc subgroup analysis. Talking about combinations, very briefly, there are no preferred combinations. We know over decades of research now that essentially combinations do not improve overall survival or patient longevity over single-agent chemotherapy. Again, maybe with the caveat where it gets done and where I would use it as well as in a patient in visceral crisis who needs a fast response. If they don't have a PARP inhibitor option, I clearly would go with dual agent in that small subgroup. And this is, I think, where the future lies. This is actually ovarian cancer data. We don't even go through the trial data, but I want you to see our ovarian colleagues at ESMO again reminding us they're doing now 4-arm trials where they're comparing a sequential therapy to combination therapy. And I think that's where we need to go in most disease areas if we have agents that have enough single-agent activity. As it's for most of the combinations that we're using, we really don't have clarity if there is synergism. And the discussion is more and more that for most combinations, there is no synergism, meaning that if we use sequential therapy, it's probably as beneficial as combination therapy. But we will only know that if we actually do the comparison of sequential therapy versus combination therapy. So the potential future biomarkers for PARP inhibitors, we currently only have phase 3 data for the germline, but the somatic data looks promising beyond breast cancer. It's already coming in other disease areas, especially ovarian cancer. They're discussing now use really across germline and somatic data, as well as HRD data. In breast cancer, we're much further behind in this regard. It's likely coming, but you should not do it off protocol. Patients should be encouraged to go on trials to get the answers to these questions. While there are a lot of similarities across tumors, we do find these differences that we need to parse out between solid tumors, and it's not 100% clear, and we do need to get the answers to these questions. But the clinical benefit rate for somatic data probably will develop. It's unclear which are the specific mutations that work in breast cancer. So this caveat that we've heard from Erika Mayer at ASCO this year about the HRD score, while it seemed like a slam dunk, it works in ovarian cancer to predict both platinum response data as well as PARP inhibitor data. Sure enough, in breast cancer, in the neoadjuvant setting, while it improves a little bit the response rate for platinums or cisplatin in this case, it actually is not better compared to taxane in the HRD group, and does not substantially predict platinum therapy either, and clearly does not show any superior efficacy for platinum versus taxane. So in the early stage setting, platinums should not be guided by any idea of HRD or BRCA mutation status. And we don't have overall survival data either that adding platinums, even in triple-negative breast cancer patients, improves the longevity. We do have path CR improvement, but it's still unclear if that actually translates into an overall survival improvement. And these biologic data further question the platinum use in the early stage setting. So talking about pathway choices and issues in triple-negative breast cancer, so we have the PARP inhibitors for germline BRCA1 and 2 mutations, a clear option. Hopefully we will get soon additional biomarkers. Those trials are actively ongoing, and we appreciate your support in getting those answers and finding the patients. We have the IMpassion 130 data. Again, still some questions about PD-L1 inhibitor used together with nab-paclitaxel in triple-negative breast cancer. Currently, there is this overall survival improvement in the subgroup. This has led to FDA approval. This has led to all of us using these agents, including in the first-line setting. But the question is your patient better served by these preliminary data or maybe an ongoing clinical trial that may have a more interesting question? There might be imbalances in response biomarkers that might explain these results. Also, this disconnect between overall survival and progression-free survival data, as we don't see that plateau in breast cancer that we've seen in other solid tumors. These data need to be confirmed. We need clearly response biomarkers because if you think about it, we're exposing all of metastatic triple-negative breast cancer to these agents that have substantial toxicities that can be rapidly fatal, particularly cardiac and pulmonary toxicities, and may cause long-term autoimmune disease or autoimmune-like syndromes in these patients that may complicate future therapies, particular targeted agents that has been seen in lung cancer, and we don't yet know what this means for breast cancer. So clearly, we need both for physical as well as financial toxicities biomarkers to more responsibly and personalized guide the use of these agents. And given the limited benefit of that progression-free survival of around 2 to 2.5 months, it's particularly concerning what this means to our sicker real-world comorbid patients that likely have a higher toxicity rate, and that may eliminate this limited benefit that was seen. The assay we've talked extensively about, so we won't go into further detail, but the current FDA-approved concurrent assay is the standard of care, and the metastatic site should be your primary choice to assess PD-L1 status, as well as your mutation status, if at all possible. Liquid biopsies are not quite ready yet for prime time. Hopefully in the next few years, we get those definitive data. So how about pathway choices and issues for ER-positive, HER2-negative metastatic breast cancer? CDK4/6 inhibitors, now a significant advancement in the care of metastatic breast cancer patients to prolong that chemotherapy period. We now have extensive overall survival data, now both in the first-line and second-line setting across the major clinical subgroups, including now premenopausal women, which is wonderful news. Resistance biomarkers look interesting, but not yet ready for clinical use. The key question, when should I use CDK4/6 inhibitor? Which patient can I spare it in first line and see if she does not have a prolonged response on AI alone, where I could keep her for years on a much better quality of life regimen? Those data we don't have. Those remain major questions. The subgroup analysis look like that all patients benefit. There has been some question of bone-only disease, and again, we don't know of sick or comorbid patients as they were not in trials. Clearly, the quality of life data will be critical to guide our patients and assess their preferences, if they would like the addition up front or wait for the second-line overall survival improvement. BRCA mutant breast cancer PARP inhibitors clearly prolong progression-free survival. The overall survival data is still pending. Clearly better quality of life compared to chemotherapy. And there are some emerging promising early phase data that together PARP inhibitor plus PD-L1 inhibitor appears to be a very promising strategy. And if you have a trial for your patient, that would be a nice combination to use. PIK3CA pathway now also has alpelisib together with fulvestrant, improving progression-free survival. Overall survival, again, are still pending. Reached FDA approval this year, and we have unclear benefit currently and unclear data in diabetic patients, given the hyperglycemia data that we did not have the chance to discuss today. mTOR agents, everolimus has a lack of overall survival improvement and can be more difficult to tolerate. So this question is how much use and how beneficial is this to your patient? And other agents such as AKT inhibitors and HDAC inhibitors still under development for definitive changes in standard of care. So our goal is really to provide not only high quality and value-based care, but also personalized care. You're very familiar with the major categories that we use to personalize patient care, including patient, disease data, diagnostics. Pathways now will help us hopefully to improve our evidence-based therapy options that are ever more complicated and will make it particularly challenging for the community oncologists to keep track. We are using outcomes data, obviously, to guide our patients for shared decision-making, and then supportive care, and EHR and analytic tools hopefully help us as well. I do want to highlight, again, not just comorbidities and performance status. And likely these agents, we have no data in poor performing patients. It's unlikely they're going to change the trajectory of your poor performance status patients, especially PD-L1 inhibitors. There are data emerging that in performance status 2 or worse probably will not move the needle much. And most importantly, it's really the patient preferences, their life goals, and their quality of care that matter, that drive the ultimate decisions, not our outcomes data, but what really are their main purposes in life. And we don't have time to go through the data, but in the geriatric population, we have now 2 major studies that suggest that 60 to 70% of geriatric oncology patients actually prefer quality of life as the main driver of their therapeutic choice rather than prolonging life, especially if it's just a few months that most of these agents provide. And again, reminding you that progression-free survival is just a surrogate outcome. It's overall survival, really prolonging life that matters, or improving the quality of life of the patient, as we're always increasing the toxicity rate and the total cost if we add an agent. So clearly adding an agent just to improve progression-free survival is not beneficial beneficial to your patient, as progression-free survival does not correlate with quality of life, and not in all instances does it improve overall survival either, as we find time and again, despite it being a surrogate outcome. So again, reminding you that beyond overall survival and progression-free survival for shared decision-making, we clearly need quality of life data as well as toxicity and cost data as well. And it's really the physical, emotional, social needs of the patients that we need to meet as well that may drive an unusual clinical decision beyond what our overall survival data would suggest. As we're all striving to do patient-centered care, I really see a very encouraging cultural change that is happening, that this is really a team effort, and it's the team that helps guide the patients, that helps us find the goals and preferences, what our patients really want from us, and not that curve, the progression-free survival curve in particular, that should drive our decision-making. So I acknowledge especially ESMO and ASCO presenters that have given us a lot of new data this year. It's been an incredible year in breast cancer, particularly Dr. Leubel and Dr. Rugo, and also Dr. Anderson, or Dr. Anders, very, very instrumental in getting some of the newest data together. I thank also our patients, their families, caregivers, and patient advocates that have been quite involved with our local effort and our Onco Alert, now Twitter, international oncologist group that has developed across nearly all the major continents. We're missing some Africa, especially Africa, and not too much in Asia yet. But we're about 100 colleagues that are keeping each other up to date and have these international and global discussion points now in breast cancer and Twitter. Follow us on Twitter. I think this might enrich your effort as well. And now we're very happy to answer any questions.
Certainly.
Thank you for your very attentive postprandial audience.
Any questions? No?
Yeah, a lot of new data.
We have one coming to the mic. Here we go. Two coming to the mic.
Super.
Okay, we'll let him go. He's at the mic right now. We'll do that first.
Please go.
Hi, my name's Andrew. I'm from Novartis Oncology. Just question regarding quality of life in the shared decision-making progress. Coming from the industry perspective, what data points do you think we could collect to represent that information that's valuable to patients in that process?
Really great question, and it's actually the million-dollar question that the FDA is trying to answer right now. You're right. Your question is right on point. That is still the challenge that's holding the FDA up to actually bring up a formal guidance on this issue. It's actively under discussion. And I think the FDA will come down to a very reasonable assessment. And what they're pushing for now is actually a very focused quality of life assessment rather than a broad quality of life assessment. Although so we don't know yet. We don't have standards. And there will be standards not only for every solid tumors that will differ, as well as I think they will start to differ even based on the therapy. We will probably even get specific quality of life tools for specific various therapies. Having said this, what I think we should include, what really matters to the patients, is not just the global quality of life assessment. We just actually saw in the Annals of Oncology, which drives this point home, that the global quality of life measure didn't change so much. They looked at over 4,000 early-stage breast cancer patients for chemotherapy or endocrine therapy, but when they drilled it down to some specific measures, such as cognitive function, as well as fatigue or pain, it matters. And so, including social function, actually, they found a substantial impact of endocrine therapy in the postmenopausal women on social function and cognitive function, and the reverse, actually, for chemotherapy in premenopausal women. So again, there will be differences even by subgroups, and having some key functional status will be particularly important, including social function and cognitive function beyond just your regular toxicity measures.
one more over here.
Hello, my name is Chuko Deze, and I'm a postdoctoral fellow at Celgene. And my question actually dovetails with his question. And it really, when you showed in that past figure on clinical benefit, quality of life, and also toxicity, could you, when you're thinking about ordering in terms of importance, how would you rank that quality of life compared to some of the toxicities? Which one would you think is more important? Or?
That's a really interesting question, and it actually is evolving. 5 years ago, as clinicians, we would have mostly disregarded quality of life and would have said, yes, we should know about it, we should discuss it, but it's the efficacy data and the toxicity data that drive our decisions, obviously, particularly life-threatening toxicity data. Now, the life-threatening toxicity data is kind of merged into that overall survival curve, right? So at least for healthy, non-comorbid patient, we have those overall survival curves, so they're kind of already in there. Now, you don't have that for sicker comorbid patients, so that needs real-world data and would give a more subtle answer for that. And the FDA is actually pushing for that as well, that we get some real-world toxicity data as well. But as we know that the fatal toxicities are in that overall survival curve in general. Other toxicities obviously matter as well. But for example, hematologic toxicities often are asymptomatic or maybe have a little bit fatigue, but it's not, we know that improving anemia, only if it's severe, probably has a major impact, for example, on fatigue. So our toxicity assessment, by the way, will also change in how it will be reported. There's the Tox-T that's coming that will look more longitudinally, will not just look at the main highest grade toxicity, but on the longitudinal pattern of the toxicities. And we're finding more and more this disconnect between our toxicity reporting versus the quality of life and PRO data. And again, I encourage you to look at this Annals paper in breast cancer that would suggest this as well. So I think what we'll find more and more that actually the PRO quality of life data plus the overall survival data will probably become the major drivers.
Thank you.
Any other questions? Excellent. Thank you very much, Dr. Kuderer.
Oh, my pleasure. Thank you.